permeable contact lenses are a great option. And I have a lot of families that this is their preference for their child. 6 months old, 8 months old, they're losing those soft lenses like crazy, and they're just not wanting to continue that route because it's too costly and they're having difficulty maintaining with the soft lenses. So I've switched them to gas permeable lenses, and this has been great because, if that lens falls out, they just have to clean it really well and they can reuse that lens. And it also provides great optics, easily, handleable, really high oxygen permeability. We have a lot of material options now with really high DKs. So that makes this option even greater. You also are going to get that enhanced optical quality. So if we were talking about an irregular cornea, or maybe a child that had a transplant that had irregularity following that, or high corneal astigmatism, we could mask and correct that with this gas permeable lens. You also will have enhanced tear exchange. And again, like I said, easy to handle, very easy for parents to put in and take out and find in the eye. And you have extensive parameters and customization available with GP lenses. We're not limited to one diameter or 3 base curves. We can completely customize this lens, and it can be less expensive for the families. Like I said, gas permeable lenses are a very affordable option. And if they're not having to replace the lenses as often because they are able to just clean the lens in the moment, if it falls out or falls on a surface that they can't just put the lens in right away, they can clean the lens. If they lose a soft lens and they find it an hour later, it's dried out and it's probably not great to reuse that lens. But some of the disadvantages are the child might have some initial lens awareness. There's going to be some adaptation period, and the lens can get dislocated. And on our end as practitioners, it does take a little bit more skill when you're putting the lens on, because you do need and a little bit more time, in the sense that you want to check the fluorescein patterns. You might have to do modifications to customize it a little bit more. But I will tell you, in terms of when you're comparing to an adult, lens awareness is not really a huge thing that children will complain about. They'll get used to lens pretty quickly. And you'll be able to kind of assess how they're behaving. If parents are saying they're rubbing their eyes a lot, it's watering, it's getting irritated, those will all be indications that maybe something needs to be modified. But it's really easy in office to just put some fluorescein, shine a blue light, see how it's looking on the eye, and make some modifications based off that without even having to get behind the slit lamp. So if you are going to be doing GP lens fittings in office, some essentials that you should have are a handheld keratometer autorefractor, and that's if it's available. That one's not, required, but that can be really helpful to get some initial case for you. You definitely want to try to measure the corneal diameter so you have a little bit of a reference point of where you're going to start, and some sort of diagnostic gas permeable lenses in office. It's so much easier to throw a lens in on the eye and see where you're at as a starting point, where to modify, versus trying to empirically order. In my experience, you also want to have fluorescein strips to do that fluorescein assessment, and some sort of Burton lamp or blue pen light. You're never going to be putting these kids behind slit lamps when they're young. Maybe if they're 8 and older, you might, but we really can do everything outside the slit lamp, or even using like a handheld 20 diopter with a pen light if you needed more magnification. I really am able to just do it outside of the slit lamp with a blue light, shine on there, see, have them blink, look around, and kind of assess it that way as well. You want to have loose trial lenses or a lens bar, because everything we're going to be doing is with retinoscopy for the most part. Never going to be throwing them behind a 4-opter. And definitely want to have toys with noise or some sort of movies for distraction, because it's going to take a team. If you'll have the parents in there kind of helping distract, get their attention. If they're the ones holding the patient, you might have your technician come in and be the one that's your right-hand man to help with keeping attention for the patient. And we have to move quickly. I have the luxury that I work in a hospital. And so sometimes we have those patients where, they come in several times and the cooperation's not there. They're crying. We can't get any views. And this is when I co-manage very closely with the pediatric ophthalmologist. We end up deciding, okay, it's time to do an exam under anesthesia. And so everybody that's part of that eye care team, whether the patient has glaucoma, the pediatric ophthalmologist, myself, we'll go in together so we can all get our measurements at the same time. And I'll get my corneal measurements at that visit, get keratometry values, bring in my lenses to the room, and do my entire fit and assessment while the patient is under anesthesia. This is not the first kind of line of what we would do, but it is something that I've had to do for a few patients just based off cooperation and how essential it is for us to get good measurements moving forward for they're either a monocular patient or they have glaucoma, and we've all been struggling. So this has happened. And like I said, if you're not working in a hospital setting, this will be more difficult to have this opportunity. When you're fitting a GP lens, I just want to let you know that this is a guideline, not hard and fast rules, but just a good kind of overview of where to start. I personally do not think that topical anesthetics are necessary for fit and for insertion removal. Oftentimes, kids are fussy. It has nothing to do with the lens in their eye or how they're feeling. It's the fear of just being in that exam room and not understanding what's going on, especially for infants. I always tell parents they're going to cry just because it's foreign to them. They have no idea what's going on. It doesn't mean we're hurting them. It doesn't mean, that they're uncomfortable. It's just, unknown territory. And especially if you're working with infants, they're going to cry. So I don't think adding an anesthetic is going to make any difference to that experience. And in fact, it might rile them up sooner than if I would have just put the contact lens in and gotten started. So I don't use anesthetics for my fits or for insertion and removal, but I would say that that's practitioner preference. When you're looking at diameter, you usually want to start with a 9.5 to 10 millimeter GP lens. Sometimes you'll go larger. It really depends on the patient's corneal diameter. These lenses are relatively larger than you would maybe for an adult because we're trying to prevent loss. We're trying to make sure that the lenses are centered. And so you start a little bit larger than maybe you would could think you would, because it's pretty close to something that would be in an adult eye, even though they might be a 6-month-old. Base curve, based off of the infantile aphakic treatment study protocol, you want to start with 1 millimeter to 1.5 millimeters steeper than the flattest K reading. If you were not able to get K readings, I would say start with something around 7.5 millimeters on the base curve and go from there based on how it looks on the eye. You want to make sure you do a fluorescein assessment. And so, like I said, use your blue light, take a look after you put some fluorescein, see how it's fitting. The goal is the same as if we were fitting an adult. So we want it to be well-centered. We want it to align, have, I err on the side of minimal apical clearance, just to make sure that we've got tear exchange under there. And you want to make sure you have adequate edge clearance. So you want to have about a 1 millimeter band of fluorescein at the edge. If you're looking at it in terms of curves, if you're ordering from the lab, and let's say you started with a 7.5 millimeter base curve, then you kind of want to go maybe 1.5 millimeters flatter as your starting secondary curves. And when you call your labs, they'll talk you through it. They'll help you through it with their design, but these are just rough guidelines. And you want to do your retinoscopy to refine the lens power and make sure you're ordering these lenses in the high or hyper decay materials. We're working with kids, and so we want to really make sure they're getting really good oxygen permeability, especially if they accidentally are going to be napping for periods of time with the lens. We want to make sure we're in a really high decay.